Next, I want to introduce Moritz von Ballmoos, and he's going to talk. He's our intervention. He's our minimally invasive cardiac surgery fellow this year, and has done an outstanding job. I hope he's had a great experience, and he's going to talk to you a little bit about percutaneous mitral valves, surgeon's perspective.
Can we load my talk? All right, so I'm just going to be talking a little bit about percutaneous mitral valve interventions from a surgeon's perspective, and I think previously there were some talks scheduled that also looked at Microclip and all these things, and I can tell you I won't be able to give you all the data on surgical and percutaneous options for mitral valve repair, but I think the premise to keep in mind is that less invasive is always more desirable, a lesser result is never acceptable. So what we try to accomplish with a transcatheter method for repairing or addressing mitral stenosis and mitral regurg is transcatheter therapeutics has to be as good or better than surgery. It has to be safe. It has to eliminate or reduce MS and MR, and it has to produce a durable result. So what I wanted to do is quickly look at what the needs are in the mitral space for interventions, how we're treating mitral valve disease today and how we're doing with that, and then go over to what is available today in terms of transcatheter therapeutics and what the key challenges are with those new technologies that are coming down the pipeline. In general, mitral valve disease has changed a little bit over the last 2 decades or so. There has been a dramatic decline in rheumatic mitral valve disease in Western countries. On top of that, there's been improved imaging and recognition of degenerative MR. And finally, there's been improvements in the treatment of coronary artery disease, both with PCI and medical management. And add to that the aging of the population that is generally observed, which will give you the end result, which is that the most common mitral pathologies that we see and address now are non-rheumatic degenerative mitral regurgitation and ischemic functional mitral regurgitation. So those are the goals, those are the target populations that are of most interest. So what we're doing today is really mostly surgery from an interventional perspective. There's about 20 plus things one can do to the mitral valve, but they can be split up in 5 larger categories. One is addressing the annulus. We can put on rings. They can be complete, incomplete. They can be rigid or flexible. The second category is leaflets and commissures. We can resect, augment, transpose parts of the leaflets. And we can suture close commissures or change the alignment of the commissures. We can implant or transpose the cords and implant artificial cords. And finally, there's some things we can do to help with the left ventricle and the geometry of the left ventricle. There's methods for approximation of the papillary muscles, and then, of course, revascularization in the hope of getting some remodeling of the left ventricle. The last option, mitral valve replacement, which can be done with either mechanical or bioprosthetic valves by surgical access. So what is the current state? There's 2 very recent papers I wanted to highlight for that purpose. One is the review of the STS database between 2011 and 2016. It looked at quote-unquote isolated mitral valve. It also included patients that had tricuspid repair and some had a MACE procedure for AFib. It's over 1,000 centers here in the United States, over 87,000 patients. What is interesting to see is that there's been a tremendous increase in mitral valve surgery in the United States, 23% overall increase, which breaks down to about 4.4% growth every year. That's about twice the growth of most other surgical interventions in the United States and the STS database. And the biggest increase really has been in degenerative mitral regurgitation. So again, highlighting that point that most of the mitral valve disease we see today is degenerative mitral valve regurgitation and non-rheumatic degenerative MR. What's also interesting and something that's been highlighted in previous papers is that there's a lot of so-called low-volume centers that perform 10 cases or less. In a previous study, it was calculated that the average surgeon in the United States performs 4 mitral valves a year, which is certainly a low number. A few interesting points about this review of the STS database is that 50% presented with a reduced EF, 1/3 with AFib, which probably should be addressed, as we know that atrial fibrillation in of itself has a higher morbidity and mortality independent of the mitral valve disease, and 16% get a tricuspid regurgitation repair, also TR well known to have its independent morbidity and mortality increase. The repair rate in the STS database is about 80%, 95%, so almost all patients do get an annuloplasty. Leaflet resection, relatively common, about half of the patients, and then artificial cords falling the third spot in the 23%. About 4% of the patients, all patients that have mitral valve repair or replacement, initially have repair and then followed by a replacement because the repair was felt to not be sufficient or a success at the index procedure. If the valve gets replaced, it's predominantly with a bioprosthetic valve, but 30% still with a mechanical valve. Overall mortality is low, it's 2%. It's particularly low for the repair patients and higher for the surgical replacement group. So a distinct difference between replacement and repair in the mitral valve. Another paper that also just came out is looking at the VA data. It reiterates all these points. Clearly a trend towards mitral valve repair in overall group of mitral valve surgical patients. So the majority of all patients that have mitral valve surgery get a mitral valve repair. If you look at just degenerative mitral valve pathology, clearly, again, a trend towards repair rather than replacement. If we look at other underlying pathologies, virtually everyone gets a repair, not a replacement. The one exception to that is active endocarditis, where oftentimes a repair is not feasible because the destruction or the extent of destruction may be so large that a repair is not possible. It's also important here maybe to keep in mind that if we think about transcatheter therapeutics, oftentimes not a good solution when we have an active infective issue, so unlikely to be a solution for active endocarditis, the group where we see most of the mitral valve replacement being done. If we look at the long-term outcomes and how these patients fare in the long term, same picture as previously in the STS database and many other trials and studies that have been done. Degenerative mitral valve disease, a repair always beats the mitral valve replacement. In the ischemic functional MR group, it's not so clear. The CTSNet trial demonstrated that and really put the repair and functional MR into question. But again, in degenerative mitral valve regurgitation, the largest group of mitral valve patients, the repair always beats replacement. So in summary, we see there is an increased need for mitral valve procedures. It's mostly degenerative MR and non-rheumatic degenerative MR, so flail leaflets, ruptured chordae, these kind of things. Mostly younger patients. AFib and TR are common though amongst these patients. Survival is clearly better with a repair, and the one exception may be functional MR. A vast majority of valves are getting repaired with our surgical techniques, and the one exception is maybe active endocarditis and may become functional MR, giving the data from the CTSNet trial. But overall, we have very good long-term outcomes with surgery, with low mortality and good long-term durability of mitral valve repairs. So this is the baseline, and now we find something that will beat that transcatheter technique, right? So what is out there for transcatheter technology? Right now, it's just a Microclip. There's nothing else available. And the Microclip essentially mimics the Alfieri stitch. It creates a double orifice mitral valve. It's placed by transseptal technique. So it is a truly transcatheter, percutaneous, if you want, intervention for mitral valve regurgitation. It's not suitable for anyone who has underlying mitral stenosis. Usually the cutoff is 5 millimeters of mercury for mitral stenosis across the mitral valve. So if you have some degree of mitral stenosis, but mostly MR, the moment you have more than 5 millimeters mercury of gradient, the Microclip is probably not going to be a good solution because you're going to increase that gradient. So how has the Microclip done? One of the important trials is the Everest-2 trial, which compared 279 patients, randomized 279 patients with chronic 3+ MR between the Microclip and the surgery. There was very strict anatomic inclusion criteria, mostly because the Microclip only works in a select population with certain anatomic features. The primary endpoint was a composite endpoint that consisted of freedom from death, surgery for mitral valve dysfunction, and grade 3 or 4+ mitral regurgitation. At the 1-year mark, the Microclip achieved that endpoint in just slightly over half of the patients, and surgery was 73% of the patients. It is important to keep in mind when we look at this trial and go back, and I didn't want to clutter my slide here with all the inclusion and exclusion criteria, that these patients tended to be a little bit older, a little bit more frail, not patients that necessarily represent the typical mitral regurgitation patient or the patient that presents with degenerative MR in general. So death rate was similar in Microclip and surgery. Mitral valve surgery reintervention was required much more often in the Microclip. Grade 3+ MR was comparable between the two, and adverse events were more common in surgery. So in general, we can say we have a clip that works reasonably well with similar death rates, but will require earlier reintervention much more commonly than the surgical approach to MR. How does it look at the 5-year mark? Same composite outcome. Microclip now down to 44%. So essentially, almost 2/3 of the patient that do not get a significant improvement of their MR or are death at 5 years. That, to some extent, is a result of the patients that were enrolled in the trial, because as you see in surgery, it's not perfect either, but it's certainly a difference. Death rates are similar. Mitral valve surgery, again, reintervention much more common in the Microclip, and the grade 3+ MR much more common in the Microclip group also, suggesting that the durability of in those that do survive out to 5 years is probably not as good in Microclip as it is with surgery. So how does Microclip look in the general population as it is being used on the commercial base now in the United States? This data comes from the TVT registry. It's essentially FDA approved for severely symptomatic degenerative MR, patients with prohibitive surgical risk and a suitable anatomy. So it is a specific subset of all patients with mitral regurgitation. The average age is 82 years old. If you look at the STS database, the average age of patients undergoing mitral valve surgery is 60 years, so that's 22 years older. With older age comes more comorbidity, many other things also reflected with the STS predicted risk of mortality in this group, 6 to 9% depending on which calculator you use for repair or replacement, the mortality 5.2%. Probably not awful at initially for the procedural risk, but if you look at the 1 year, it's 26%. So clearly room for improvement there. The acute procedure success is essentially based on the initial TEE or post-procedural echo. That means 91.8% sounds pretty good, but that would be equivalent to leaving the OR where 10% of the patients have still significant 3+ or 4+ functional mitral regurgitation. This slide just sort of shows in a graphic the same message all over again. If you keep that in mind and think back to the slide I showed previously for surgical repair of functional and degenerative mitral regurgitation, yes, probably not exactly a comparable group if you look at all comers in the surgical group, and these patients that have been getting the Microclip are in general sicker, are in general more fragile patients, but overall not necessarily great results, but it does work, and if it does work, it works well. So what other trials are out there for Microclip, and what are we looking at currently? There's the COAPT continuous access study, the ReShape heart failure, and the MITRA-FR trials. Just to mention a few, those are all trials designed to look at functional MR, because because again, the Microclip here in the United States is approved only for degenerative MR, not for patients with FMR. We do know from registries and observational studies that there's an increasing group of patients with FMR where the Microclip is being used off-label, and that sort of was the nidus for these trials, to look at that and see what the benefits are in patients with FMR. What else is out there? Well, there is the Pascal device, which just looks like another Microclip. Then there is Cord Solutions, the Harpoon device over here, the Neo Cords. Both of them are devices that come in transapically and place Neo Cords in the mitral valve leaflets. There is the Carillon, which has been investigated mostly in Europe, which is a metal frame essentially that's placed in the coronary sinus and aims to reduce the mitral valve annulus. There's the Cardioband, which is currently being investigated in the United States and has CE mark in Europe. And then there's the Millipede, which is coming up with another attempt at creating a ring annuloplasty in the mitral valve. This is only a very small selection and sort of those that are the furthest along in their development and investigation and clinical trials. There's about 30 or 40 more devices out there that are being designed or being tested in first in man. So a lot of things out there, but nothing currently available. So what about TMVR, transcutaneous mitral valve replacement? Well, there are significant challenges with development of a TMVR solution. Currently, all of these platforms are transapical, so we essentially do not have a percutaneous method. We make a thoracotomy, much like we do for a minimally invasive mitral valve repair or replacement. We have to go through the apex, which is not necessarily a benign thing to do, may not be such a big deal in a patient with a burned out LV and a bad left ventricle, but it is a big deal in anyone really going through the apex and distorting the anatomy and the function of the left ventricle. There's multiple valves that are in development and under investigation. Currently, about 150 valves or so have been implanted worldwide, so the experience is very, very early on, and it's very limited. The mortality for some of these implants is between 20 and 50% because there is a lot of challenges because the patients they have been tested on are very sick. There's just two valves I wanted to show you, sort of representative for all the valves that are out there, which are about 15 or 16 valves now. The cardiac valve, which has CE mark in Europe, essentially has these little hooks at the bottom that help with the implant. It has a stent portion. All of these things try to fit it into the mitral valve. The Tendyne valve over on this side, which is a little bit a different concept. It's like a parachute and then has this apical pad that fixes the mitral valve and sort of holds it in place. So these are just two valves of many, many out there. There's significant challenges with TMVR, some of which include the shape of the mitral annulus. It's a D shape, it's not a round shape, like the aortic valve, for example, that is also not exactly round, but oval, but more conforms to a round shape if you force it to. The mitral annulus really doesn't want to live in a round shape. It's difficult for both the anchoring of a device. There is difficulty to get a good radial force and distribution of this radial force in the annulus. For those of you that have been to the cardiac lab, we looked at the mitral curtain. That is sort of the anterior portion of the mitral valve. In the back you have the big ventricle, so you have a lot of support in the back, although you don't want to squeeze too hard there because you have the coronary sinus and the circumflex, and in the front you have almost nothing. So not an easy task to anchor something and place something in the mitral annulus. The imaging also a significant challenge. How do we size the valves? How do we find the correct size both for the annular shape that is not round and for the LV obstruction that can occur with implantation of these valves? There's lack of support, again, in the native mitral annulus, and then even those patients that do have some mitral annular calcification, there's a varying degree of that. There's varying degree of platelet calcification, portal rupture, inward dilatation. So there's a huge variation in landing zones. Unlike TAVR, for example, where most of the patients have significant calcifications and which provides that framework, and have all tri-leaflet valves, as we know, and bicuspid valves hasn't done so well. A lot of consistency in the TAVR space, not so much in the mitral space, where there's a lot of variation again in the substrate where we try to place these transcatheter valves. It's a large annulus, means larger devices, means much larger delivery system. That is why most of the devices currently under development or in trials are transapical. It's just not feasible currently to do that transseptal. I'm sure someone will come up with a way to make these devices smaller at some point, but we're clearly not there. The other problem, LV obstruction with placement of a transcatheter mitral valve. As you can imagine, when you place a TAVR valve, what you push out is the aortic valve leaflets, and you push them out to the side, and if you have a large enough sinus, you won't get coronary obstruction, but that's what you're concerned about. You place a TAVR valve, you're concerned you're going to be obstructing your coronary arteries. On the CT scan, we can measure the aortic sinuses, we can measure the leaflets and how high they're approximately going to be. So we have a lot of ways to predict the risk of coronary obstruction. In placement of a TAVR, of a transcatheter mitral valve, it's a little bit different. It's hard to predict how much LV obstruction you will eventually get if you place a transcatheter mitral valve, especially if you have dynamic conditions. We also know that paravalvular leak is one of the Achilles heels of all the transcatheter mitral valve, or all the transcatheter therapeutics. As Dr. Ritten pointed out, paravalvular leak is much a bigger problem in mitral space because you're essentially subjecting your valve to a systolic pressure gradient. There's also been slow enrollment in trials. There are several reasons for that. There's competing trials, so everybody wants to get that same patient. The exclusion criteria are pretty broad, so it's hard to find the right patients, and it's kind of a rare demographic what is currently being sought for these trials. The current trial in the United States is the Apollo trial, which looks at the Medtronic Intrepid valve. It aims to enroll 1,200 patients with severe symptomatic MR. There's very strict demographic and anatomic requirements for that. There's two arms, one non-surgical for non-surgical candidates, and then the second arm for high-risk surgical candidates, both of which are randomized either against the Medtronic Intrepid valve. Early results for that are expected in 2021, so not next year or the year after, so it's going to be a while until we have good, robust data on how TMVR really fares. So going back to what are the needs we need in mitral valve pathologies, we have an increasing demand for mitral valve procedures. Mostly it is degenerative non-rheumatic DMR. It's younger patients with AFib and TR, so we need a solution for that. Survival is definitely better with repair, which makes TMVR a little bit less attractive. The vast majority of valves get repaired, and we have good outcomes with surgery. So currently there's only the Microclip with approval for inoperable DMER. The valid TCT approach to the mitral valve will require a multifaceted approach, which means we'll need probably different tools, and which means we have a different learning curves for different tools that we'll have to learn in order to do that safely and efficiently. There's currently limited solutions for comorbidities for AFib and TR in the TCT space. The mitral valve replacement is really only an option if it can't be repaired, whether that be with TCT or surgery. And again, TMVR is a little bit more complex than TAVR, so not likely to see the same development in the TMVR space as with TAVR. So fixing a mitral valve problem, it's not far, but it's complicated. So we have all the right ideas probably, but it's going to take a while to really implement them and come up with good solutions. TMVR has a long way to go. There's a small subset of patients where this eventually will be a good solution. There's multiple tools for mitral valve we will have to learn and adopt. We'll have to essentially simulate what we try to do now with surgery. That means we'll have multiple learning curves with multiple devices. TCT should become eventually transeptal, because if you have to do transapically, you really haven't accomplished much in terms of being minimally invasive. The TCT repair must preserve the option for surgical repair. I'm personally convinced, because if you burn the bridge for a surgical repair and you have a bad result with a TCT repair, what you're going to end up with is going to be a surgical valve replacement. Thank you.